So good morning everyone and respected judges. I will be presenting a paper on microscope integrated OCT or MIOCT guided stromal fluid drainage in cases of recalcitrant corneal hydrops. So what is a hydrops? Hydrops is basically there is a breach in your descemet layer and the aqueous humor percolates and that leads to corneal edema, stromal fluid pockets and epithelial edema. So what do you mean by recalcitrant corneal hydrops? A recalcitrant hydrops is something which doesn't resolve on medical management or one attempt of intracameral C3F8 injection. This is the normal plan for any corneal hydrops. As you can see here, medical management or surgical management. But if this doesn't work, then we label it as a recalcitrant corneal hydrops. So what are the implications why we did this study? Because if you delay the edema, there may be corneal infection, there may be corneal neovascularization, corneal fistula formation, all these complications can occur. So we reviewed the literature. However, in literature there are only few studies. One about MIOCT guided drainage plus compression suture, one about platelet rich plasma, and most of them C3F8. So we plan to say this brings to the purpose of my study, that is to evaluate the role of real time MIOCT guided stromal fluid drainage in recalcitrant corneal hydrops. We did this in our tertiary care center. It was a prospective interventional case series. We included all patients of recalcitrant hydrops from the period 2020 to 2022, and we obtained ethics clearance from the AIIMS New Delhi, and then we did that study. So this is what is the basic steps of the surgery is like. I'll show you a video briefly. So the point is, as you can see in MIOCT, you can see a lot of fluid pockets here. So what we do is achieve an anterior chamber tamponade and then drain these fluids by making MBR incisions. Start from the periphery, avoiding visual axis, and then go till to the lumen of the pocket. So this is a brief video. I'll just skip it. As you can see here, initially paracentesis is made, the anterior chamber tamponade is achieved, and this using a MBR knife, which is guided by your MIOCT, you can enter these pockets and drain the fluid pockets. You can use massage to drain whatever fluid is there, and this is the appearance at the end of the procedure. You can see all the fluids have been drained. So so we took 6 patients for this. All of them had keratoconus. Almost 4 out of 6 had VKC, and one was IFC and one was Down syndrome. And you can see the median presentation time. All of them had hydrops for more than 30 days or more than 4 weeks. The median thickness was quite high. It was almost 1625, and this was the post-op outcome. As you can see, almost all of them resolved, and surprisingly, one case resolved within 1 week of the intervention. No, one patient had increased symptoms at 6 weeks, but however, that could be controlled medically. All of them had a scar at the end of the follow-up, and the follow-up period was 6 months. So these are few examples how it performed. When we compare this with available literature, as I said, there was a report of compression suture. Some people have tried DMEC. However, the advantage of this technique is it's a one-time procedure. You need not remove the suture in contrast to compression suture. So MIOCT guided fluid drainage in recalcitrant hydrops is a safe and effective technique. It ensures complete drainage of the fluid, so avoiding all the long-term complications of persistent corneal edema. The limitation is availability of MIOC. It's not available everywhere. However, you can take guidance from your pre-op AIOCT image, and also you can perform the same procedure. And you are making multiple entries that carries a risk of infection, fistula formation. However, we haven't encountered any such complication till now. So it is a safe and effective procedure, but we may need more studies from more center. At present, I don't think other than RP center, any other center performs this. With this, I will conclude here. Thank you very much. Thank you.
Because anybody can present, because there is no time. I'll note down your name, no problem. Navneet. Okay. Navneet Chabra.
Yes.
Okay. You can proceed.
The first.
Your topic is congenital corneal staphyloma.
Yes, sir. Good morning, everyone, and the esteemed judges. I'm Dr. Navneet Chabra from Mahatma Gandhi Institute of Medical Sciences, Sevagram. I'll be presenting a case of congenital corneal staphyloma, a misdiagnosis or a misdiagnosis. Congenital corneal staphyloma is protrusion of an opaque ectatic cornea and an enlarged globe in between the lids. The case history was given by the parents who bought a 6-day-old full-term neonate with the complaints of left eyeball and globe protrusion since birth. The baby was born from normal delivery after a spontaneous conception. There was no history of any birth trauma, intranatal or postnatal infection, and no history of NICU admission or any drug exposure. The baby had a birth weight of 2400 grams and was born to a parents who had a non-consanguineous marriage. The baby was the first live birth and the parents had a previous history of abortion. On general examination, the baby was active and had polydactyly on the right feet. No systemic abnormality was detected. On ocular examination, we found that the left eyeball had an enlarged globe with an ovoid mass protruding antero-inferiorly in between the lids. The mass was soft to firm, non-tender, with a reddish-black surface discoloration. There was no transillumination present and the rest of the intraocular details could not be identified. The right eye examination showed direct pupillary reflex present and absent consensual light reflex. The anterior segment examination and dilated fundus examination were within normal limits. On performing the magnetic resonance imaging of brain and orbit without contrast, we found that on axial scan, the anterior-posterior length was 23 millimeters with an enlarged anterior segment and focal corneal thinning. There was outpouching of the globe anterior to the rectus muscle, as you can see in the inferior scan, and there was no intraocular calcification scheme. There was anterior-inferiorly displaced lens with an hyperintense area on the posterior corneal surface, which was suggestive of the presence of uveal tissue in the baby. The other extraocular structures and the right eye examination was normal. There was no MRI orbit, no abnormality on the MRI brain. On performing the ultrasound B scan, we found that the baby had an increased axial length in the left eye of 21 millimeter with an irregular anterior corneal surface, no cataract or retinal and choroidal detachment. Right eye ultrasound B scan showed no abnormality. To detect the chromosomal analysis, we found that the baby had a 46XX karyotype, so the chromosomal analysis was normal, and molecular genetic reports have been done and are awaited for results. The human cornea develops on the 33rd day of gestation. The mesenchymal cells, which arise from the neural crest cells, develop the anterior part of the corneal stroma, the Bowman's membrane, the Desmond membrane, and the corneal endothelium. Congenital corneal staphyloma is a severe form of mesenchymal dysgenesis and is considered to be a variant of Peters anomaly, which is caused due to abnormal neural crest cell migration. The PITX3 gene, which is mapped on the chromosome 13, is associated with congenital cataract, anterior segment dysgenesis like this condition, Peters anomaly, and microphthalmia. A single case has been reported from China, which shows that the corneal staphyloma is seen in patients with PITX3 gene variant. On chromosomal analysis, as I have already previously mentioned, we had a 46XX chromosome karyotype, and we are waiting for the cytogenetic reports for PITX3 gene. These babies have a poor visual prognosis and are mostly treated either by enucleation and, if detected early, by penetrating keratoplasty. We are following up our patient and we have confirmed our clinical diagnosis by magnetic resonance imaging, which showed an enlarged globe, ectatic cornea, antero-inferiorly displaced crystalline lens, thus confirming the clinical findings with the MRI findings, which was similarly seen in the study conducted by Al-Judabi et al. These are the serial photos of baby which was monitored by us. Finally, I would like to conclude that congenital corneal staphyloma is a rare clinical entity, and diagnosing and clinical examination of this is a clinical dilemma, especially in neonates. So we need to report these kind of cases. To the best of our knowledge, this is the rare clinical presentation, and no such case has been reported from India. So we are presenting this case to report its rarity. And finally, I would like to say, if you find these patients next time, let's not miss the diagnosis and misdiagnose this condition. Thank you.
Next, Dr. Lipsa Mahapatra is here. Dr. Lipsa. You are Dr. Lipsa? Okay. Your topic is prospective study of corneal biopsy in patients undergoing therapeutic penetrating keratoplasty. Okay, you can proceed.
Good morning, everyone. Myself, Dr. Lipsa Mahapatra, now going to present on the topic of a prospective study of 32 cases of corneal biopsy in patients undergoing therapeutic keratoplasty at a tertiary healthcare center in Western Odisha. Corneal blindness. It is the fourth leading cause of blindness worldwide, contributes to about 7% of global blindness. 90% cases of infectious keratitis and trauma are the major contributors of corneal blindness in developing countries. Infectious keratitis cases commonly present with large or perforated ulcer or endophthalmitis due to delayed or inappropriate treatment, lack of infrastructure for appropriate investigation, non-compliance with follow-up due to financial reasons, or non-responding to therapy. All these cases may require therapeutic penetrating keratoplasty. TPK, it is means the use of corneal graft for terminating or improving active infection and to establish globe integrity, eliminate infectious foci with visual rehabilitation. Histopathological study of the excised cornea is a must, and corneal biopsy determines the corneal pathology. The objective of a study is to report the histopathological findings, clinical outcomes of corneal biopsy following TPK in a tertiary healthcare center in Western Odisha. My study place is Department of Ophthalmology, Pathology, Microbiology, and study duration is from January 2022 to May 2023. It is a prospective study design, and my study population includes total 32 cases of underwent TPK during the study duration. A standardized protocol for infectious keratitis management was followed in each cases. All cases underwent microbiological evaluation on presentation, irrespective of their first diagnosis and treatment. Patients with intact globe integrity had B scan ultrasound before surgery to rule out posterior segment infection, spread, or anatomical complications. Examination of donor tissue size, quality of the graft, and grading of the donor cornea must be done in every cases. Outcomes are classified into anatomical success, therapeutical success, and functional success. And graft outcomes are categorized into clear graft, graft infection, primary graft failure, and graft rejection. This is the pre-op and post-op picture after therapeutic penetrating keratoplasty. This is the another picture showing of a patient presented with corneal ulcer after pre-op and post-op picture. This is the histopathological examination of the corneal biopsy showing acute inflammatory ulcerative lesion. Coming to results, among the 32 cases of TPK, the median age group is 55 years, among which 78% are men and 50% are presented with visual acuity of hand movement to 1/60. Most of our infectious cases, that is 65%, among which 33% are fungal causes. Coming to histopathological findings, 37% are inflammatory causes, 31% with corneal degeneration, 21% with corneal dystrophy, and 9% with carcinomatous changes. The primary goal of TPK is to achieve the eradication of infection and restoration of global integrity, timing of patient presentation, accessibility to medical and microbiological facilities, ability to initiate apt treatment, and patient compliance have significant impact on outcome. Socioeconomic factors and geographic location of patient contribute to the delayed patient presentation. In such instances, early TPK could yield better outcomes. Postoperatively, patients operated for fungal corneal ulcer and bacterial corneal ulcer received frequent topical antifungals and antimicrobials for at least 3 weeks respectively. Our study highlights the diverse histopathological findings encountered in Western Odisha and emphasizes the importance of early diagnosis, timely intervention in the management of corneal diseases. Further studies with larger sample sizes and longer follow-up periods are warranted to enhance our understanding of corneal pathology and improve patient outcomes in this region. My take-home message is to emphasize the importance of corneal biopsy as a diagnostic tool in guiding treatment decisions and improving outcomes in patients with corneal disorders, ultimately highlighting the need for its incorporation in clinical practice. Thank you.
The next presenter is Dr. Sucheta Kaul. First presenter. We have another order of list. Okay. Dr. Sucheta Kaul is here. Oh, you can please. The topic is allogenic slit in chronic VKC. Sucheta Kaul, Dr. Sucheta,
Yeah.
Your topic?
Yeah.
Okay.
Good morning, everyone. I'm Dr. Sucheta Kaul from LV Prasad Eye Institute, Hyderabad. I'll be presenting a study on allogenic simple limbal epithelial transplantation in chronic vernal keratoconjunctivitis. So VKC is a bilateral atopic condition with recurrent episodes, and chronic inflammation can lead to limbal stem cell deficiency. In the study by Wazirani et al., allergic conjunctivitis was one of the main causes of bilateral LSCD. Limbal stem cell transplantation should be considered as a treatment option in bilateral cases of LSCD. Ideal criteria for SLET are wet ocular surface, no symblepharon, and a clear to translucent corneal stroma. Objective of the study was to assess the outcomes of performing allogenic SLET in patients with bilateral LSCD in chronic VKC. So these patients with bilateral LSCD due to chronic VKC not improving with conservative management, having wet ocular surface were included, and patients having acute episodes of VKC with infections or inflammation were excluded from the study. It is a retrospective observational study which took place from September 2019 to August 2023 and included cases operated by a single surgeon. The sample size was 6 eyes of 3 patients with chronic VKC. Methodology. So after taking a detailed history, serial slit lamp photography and baseline ASOCT was done for the patients. After that, they were given conservative management. Those who failed to get benefit from the conservative management further progressed to surgical management by AlloSlit. Post-op slit lamp photography and ASOCT was also done. So this was our first patient, which we can see presented to us with total limbal stem cell deficiency with a fibrovascular panels on the surface. Right eye BCVA was 20 by 200 and left eye was counting fingers. This was the ASOCT which shows thickened cornea with a hypertrophied epithelium but a clear stroma. The second case presented with right eye BCVA of counting fingers and left eye of hand movement. The ASOCT presented a similar picture. The third case had right eye BCVA of finger counting, but the left eye BCVA was 20 by 30 owing to the clear central cornea and partial limbal stem cell deficiency seen in the periphery. And this was the ASOCT of the patient. All the patients were given conservative management with chromal fort, tacliment, and tapering doses of topical steroids. After giving the conservative management, the patients who did not get much benefit underwent allogenic SLET. So 360-degree perilimbal conjunctival peritomy was done, and panels were separated from the cornea. Amniotic membrane was secured with fibrin glue. The limbal stem cells were then harvested by SNP biopsy, and the tissue was further cut up into multiple pieces, fixed with fibrin glue concentrically over the mid-periphery of the cornea. BCL was placed and a temporary tarsorrhaphy was done. Post-op management included tapering doses of steroids, antibiotic, chromal fort, and tacliment in all the patients. Also systemic immunosuppression with tablet Visolon, 1 mg per kg body weight OD in tapering dose, as well as tablet cyclosporin 50 mg BD in 2 patients, and tablet methotrexate 7.5 mg OD weekly in 1 patient was given. Results. The 3 subjects which met the criteria of bilateral LSCD, out of the 6 eyes, 5 eyes went under allogenic SLET. Male to female predominance was 1:2. Allergic rhinitis was present in 1 patient. And out of all the 3 patients, we can see that all of them had a prolonged duration of symptoms and had a childhood onset. Histopathologically, the characteristics seen in VKC are as shown in the images. The first image shows a hypertrophic epithelium with epithelium downgrowths as seen by the black arrow. Cellular infiltration is also seen. The second and the third image shows cystic and solid pearls. These same characteristics were also seen in the panels dissected in our cases. So the post-op vision for the first patient in right eye improved to 20 by 100, left eye improved to 20 by 50. The second patient right eye improved to 20 by 250 and left eye to 20 by 40. Third patient right eye improved to 20 by 50. So these are the post-op images of our first patient showing clear corneal surface and the ASOCT, which shows the normal corneal thickness as well. This was the second patient with the normal ASOCT and the third patient. So SLET has multidirectional growth of epithelial cells which consecutively merge and form a epithelium over the corneal surface. This process takes 14 days after the surgery. In a study by Shanbag et al., it was deduced that in chronic ocular allergies, allogenic SLET with prolonged systemic immunosuppression has benefits in treating bilateral LACD. So to conclude, VKC with advanced bilateral LACD can be successfully managed with allogenic SLET. Systemic immunosuppression is essential in these cases to ensure the functioning of the graft and also has an additional benefit in the ocular allergy. Pros lenses can improve the visual acuity, but it should be made sure that the fit is good so that there is no mechanical compression affecting the health of the limbal stem cells. Thank you.
Next, Dr. Atidhi Tripathi. Dr. Atidhi Tripathi is here. Okay. Next, Dr. Nivedita. You can start now.
Good morning, everyone. Today I'm going to present my paper on the topic comparison of dry eye disease post-LASIK between contact lens wearers versus non-contact lens wearers. We do not have any financial interest. Our aim is to evaluate dry eye following conventional LASIK in patients who are contact lens wearers versus non-contact lens wearers. Prospective interventional non-randomized study was done which followed the tenets of Declaration of Helsinki and was approved by the Institutional Ethics Committee. Dry eye symptom evaluation was done by the Indian Dry Eye Questionnaire. All patient has measurements of tear film breakup time, tear meniscus height, corneal topography through orbs scan, objective scatter index through HD analyzer, preoperatively and postoperatively on day 15th and 3 months. This is the Indian Dry Eye Questionnaire which we used, in which symptoms were assigned scores. Scores of 0 to 6 signifies mild dry eye, 6.1 to 12 were moderate, and 12.1 to 18 indicated severely symptomatic dry eye. Patients of age more than 21 years with a spherical equivalent between -1 diopter to -10 diopter and minimum corneal thickness of 500 microns were included. Soft contact lens wear was discontinued 10 days prior to LASIK. Following patients were excluded, which includes patients using rigid contact lenses, patients with keratoconus, active keratitis, corneal dystrophies, cataract, diabetic retinopathy, history of trauma or recent surgery, patients on corticosteroids or immunosuppressants, pregnant and lactating women, and objective scatter index more than 1. Mean age in group 1, that is contact lens wearers, and non-contact lens wearers was comparable. The gender didn't significantly differ between the two groups. Best corrected visual acuity was comparable both preoperatively and postoperatively in both the groups. Spherical equivalent was also comparable in contact lens wearers as well as non-contact lens wearers preoperatively and postoperatively. Objective scatter index was significantly different in preoperative and postoperative day 15, contact lens wearers being on the higher side, and it eventually got comparable at post of 3 months. The dry eye symptoms score was more in contact lens wearers significantly preoperatively as well as postoperatively in both the groups. The tear film breakup time was comparatively more in less in contact lens wearers as compared to non-contact lens wearers, both preoperatively and postoperatively. Tear meniscus height was significantly on the lower side in contact lens wearers as compared to non-contact lens wearers preoperatively and postoperatively on day 15th, and eventually got comparable in both the groups post-op 3 months. To conclude, contact lens wearers have significantly higher incidence, that covers the 86% of dry eye disease after LASIK as compared to non-contact lens wearers. Patients with lower tear meniscus height are more susceptible to dry eye disease induced by LASIK. Post-LASIK dry eye persists for longer duration, that is more than 3 months in contact lens wearers. Dry eye symptoms after LASIK may lead to poor patient satisfaction and impairment of quality of life. Contact lens wearers post-LASIK dry eye should be aggressively managed with tear supplementation, omega-3 fatty acid supplementation, and or punctal occlusion. To conclude, my take-home message is contact lens wearers have more severe dry eye disease as compared to non-contact lens wearers post-LASIK. These are my references. Thank you so much.
Okay, doctor, thank you. The next presenter is Dr. Maunika. The topic is blinded by nature and neglect, a case study on toxic keratitis. Dr. Maunika.
Shall I start, sir? Good morning, I am Dr. Maunika. Today my case presentation is on blinded by nature and neglect, a case study on toxic keratitis. Coming to introduction, toxic keratopathy is defined as a corneal pathological changes or a functional disturbance with or without any inflammatory response caused by accidental exposure to topical or systemic medication and associated preservatives or breakdown products of the drug. Due to its potential site-threatening nature, toxic keratitis must be recognized and managed correctly. So, a retrospective observational study was done in 48 patients with toxic keratitis over a period of 6 months, of them male being 32 and female 16. Age group, they presented from 16 to 60 years, and presentation to the hospital was within 6 to 48 hours. Occupation, most of the patients were farmers, flower vendors, household work and students. Activity at the time of injury, plucking flowers, gardening work, applying henna, custard apple seed powder to the hair. Coming to etiology, 37% of the patient had accidental exposure to plant sap, 27% has accidental exposure to calotropis juice, and rest 10% to custard apple seed powder, and 13% with henna and topical drug abuse. So these are the different presentations. Patient presented with punctate epithelial erosions, epithelial defects, corneal edema with Desmond folds, and reactionary hypopyon and corneal infiltrate. So most of the patients, like 70% of the patients presented with punctate epithelial erosions and 44% with epithelial defect. Rest presented with corneal edema, Desmond membrane folds, hypopyon, pseudodendrites, iridocyclitis, and only one patient presented with severe corneal infiltrate. So we have treated the patients accordingly. Patient who presented with punctate epithelial erosions and epithelial defect, early topical lubricants and 0.5% moxifloxacin eye drops 4 times per day given for 3 days and reviewed again. Patient who presented with Desmond membrane folds and corneal edema, a combination of antibiotic and steroid eye drops of 0.3% gatifloxacin and 0.1% prednisolone 6 times per day, along with a cycloplegic 0.1% homemade eye drops BD were given. Patient who presented with reactionary hyperpion and keratic precipitates, a combination of antibiotic steroid eye drops, too early for 3 doses, then with tapering doses. Along with that, cycloplegics and anti-glaucoma medication, BD were given for 1 week. Patient who presented with an infiltrate, after performing the necessary investigation, we have started the patient on fortified cefazolin 5% eye drops hourly for 2 weeks, then 8 times per day for 2 weeks. Along with that, 5% atomycin eye drops hourly for 2 weeks, then 6 times per day for 2 weeks. Along with that, cycloplegics and anti-glaucoma medications were given. One patient presented with pseudodendrite. We started the patient on 0.5% moxifloxacin eye drops hourly for 2 weeks, then 8 times per day for 2 weeks, along with topical lubricants hourly, followed by cycloplegics. So results, patients were followed up on day 1, 3, first week, second week and 1 month. Most of the patient gained visual potential within 2 weeks. Patient with corneal infiltrate and hyperpion recovered within 1 month. So these are my results. Most of the patients' visual acuity ranged from 6.9 to CF 1 meter. Most of the patient gained visual acuity within 2 weeks. The patient who presented with poor visual acuity at presentation was the last one to recover. All the eye signs and symptoms got recovered within 2 weeks. The patient who presented with infiltrate was the last person to heal, which took us 1 month. So this is an interesting case. A 32-year-old female presented with accidental exposure to custard apple seed powder. While on presentation to the hospital, we have noticed a 7 mm infiltrate. After doing the KOH mount and gram stain, in gram stain we have ruled out Staphylococcus aureus. So we started the patient on topical cefazolin 5% hourly and topical 2% atropine eye drops, and oral analgesic were given. Post-op, like day 30, patient healed with scar. Coming to discussion. So, Plansap, it is usually toxic to the epithelium due to its acute acid injury, and it also produces contact dermatitis. Calotropis is of again 2 types. It may be Calotropis procera gigantina. Most of the time, Calotropis juice is non-toxic to the epithelium and toxic to the endothelium. The latex which is present in the Calotropis leads to release of histamines, which in turn activates the inflammatory cascade, leading to descendant membrane folds and stromal edema. We have performed a specular microscopy in patients who presented with accidental exposure to Calotropis juice. There is a significant polymecathism and pleomorphism. After day 30, we have again taken the specular microscopy where the results were good and the polymecathism was not observed. Patient who presented with tropical drug abuse, usually there will be a disruption of intercellular spaces and decrease in microvilli and prominence of cell nucleus, which leads to disruption of epithelium and leads to punctate epithelial erosions and epithelial defects. And seeds of Annona squamosa, also called custard apple seed powder, contain active components such as alkaloids, cyclohexapeptidates and acetinogens, which are toxic to the epithelium. So my conclusion, misdiagnosis of toxic keratitis is sustained or increased use of medication leads to vicious cycle that can potentially threaten the vision. So my study emphasizes the need for the patient and clinician education for prevention and management of lesser known toxins to prevent ocular morbidity. These are my references. Thank you.
Thank you, doctor. The next presenter is Dr. Aditi Tripathi. She is going to present outcome of retreatment with Bowman's membrane lenticule in glue BCL treated corneal perforation.
How to start? Start?
Okay, doctor, you can proceed.
Very good morning to everyone. My name is Aditi Tripathi. I'm here to present my paper on outcome of retreatment with Bowman's membrane lenticule tuck-in in cases of corneal perforation previously treated with cyanoacrylate glue with BCL. As we all know, corneal perforations are an ocular emergency with myriads of causes like infections, autoimmune diseases, loss of corneal innervation, and it is always our main goal to restore the integrity of globe as soon as it's possible and to minimize the complications associated with it, such as synecdoche formation, glaucomas, cataract and choroidal hemorrhages, and the most dreadful of them all, endophthalmitis, that can lead to panoff and autovisceration. In our literature, there are several methods and modalities to treat the corneal perforation, such as patching, scleral contact lenses in glue, and Gunderson flaps and AMTs, and the more surgical definitive measures such as penetrating keratoplasties. But corneal perforations are relatively resistant to treat, and we are always working towards finding a newer and innovative method to treat them. Cyanoacrylated glue, as per se, is a temporizing measure which only is a mechanical barrier. It provides a mechanical barrier by polymerizing and solidifying, and also requires multiple layer of application on the ulcer bed, with the complication when it comes in contact with the lens or endothelium of the cornea. It causes toxicity, it causes damages, and it causes extreme ocular discomfort for the patient himself or herself. Whereas when we use Bowman's membrane, which is also known as anterior elastic lamina, which is a strong acellular innate non-antigenic layer of the cornea, about 8 to 13 microns in thickness, it acts as a strong support for the epithelial growth and strengthens with the age. It can be glued, it can be sutured, it can be tucked in. It also provides a reinforcement for the thinned out cornea, which neither the AMTs, unlike AMTs, which are antigenic, Bowman's membrane have the tensile strength and the thickness. Bowman membrane also provide a base for the nerve regeneration. It remains stable, and seldomly the patients require further intervention with the invasive surgery. Bowman's membrane has been studied, grafting has been studied in the advanced keratoconus to stop its progression and to stabilize the cornea. My purpose is to compare in the failure surgeries of cyanoacrylated glue with BCL, like in patient symptoms and patients low visual acuity, to compare them with the Bowman's membrane lenticule tuck-in cases. The primary objective would be to estimate and document the gain in the BCVA compared with the preoperative values, and to study the re-epithelialization of the cornea using the fluorescent sodium dye, and to study the healing by duration of the stable re-epithelialization of the cornea. The secondary would be to assess the complication and safety of the procedure. The study was conducted at a tertiary care center, hospital-based, prospective, comparative type of intervention study from January 21 to June 2023. The study was approved from the Institutional Ethics Committee. In this study, we took 10 eyes of 10 patients of corneal perforations with specifically non-infective etiology like trauma, previously treated with cyanoacrylated glue with BCL elsewhere, and patients who had active infections or who were unwilling for this innovative surgery, or those who were unable to come for follow-up, were excluded. We did a baseline examination, systemic, clinical, ophthalmological. We did a BCVA testing, slit lamp biomicroscopy, ASOCT, corneal sensitivity testing, as well as conjunctival smears to rule out any active infection in the cornea or in the ocular surface. All the surgeries were performed by one surgeon only, and the donor tissue was of therapeutic grade, which cannot be used for PK, and they were procured from our state eye bank. So the inclusion criteria are all the patients with less than equal to 2.5 mm corneal perforation. So we included only micro perforations in our studies, and patients with collapsed anterior chamber or with the high risk of hypotonic maculopathies, or patient who wants to improve the quality of their vision, and patients who are willing to give the consent for the surgery. Exclusion criteria were all the patients with the active infections, bedridden patients, debilitated, and we specifically not included the patient with a history of corneal transplantation and the history of fungal keratitis and vegetative metatrauma, as well as one-eyed patients were also excluded from the study. The methodology, I would like to show you all a video. So this is a procedure to harvest the Bowman's membrane. The first step is to scrape the cornea with the 15 number blade, then we stain, we scrape the epithelium, then we stain with a trypan blue dye, Orolab. We create an emphysema in the anterior stromal layer by injecting the air to separate the Bowman's from the anterior stroma. We, with the help of a corneal refine, according to the size of perforation, we decide our graft corneal button is. Please mind that all these corneas are therapeutic grade. With the help of this iris repositor, we are trying to separate the Bowman's membrane from the anterior stroma. And it is, since it is an internal elasticity, it rolls on itself, single roll, double roll, with the epithelial side on the border. This is a presentation slide showing. Time is up.
Can you finish it fast?
Sorry, sir. Yeah, and so this is a proof that we only harvested the Bowman's layer. This is the surgery which is showing after scraping the glue off, by removing the glue, from the perforation, we created a recess. So basically the surgery is we create a circumferential 360-degree recess. In the case of central perforation, it is about 8 to 9 mm. And in case of peripheral perforation, the recess is created about 3 to 4 mm. After creating the recess, before that also we remove any debris or dead cells while scraping the cyanoacrylate glue. The Bowman's membrane that we harvested from the therapeutic grade donor corneas is tucked inside the recess we have created. An anterior chamber is formed and the surgery is done. These are the steps showing the PPT. And the post-op regime, we did not give any topical steroids. We only give the moxifloxacin, that is antibiotic eye drops and lubrications. And patients were followed up on day 1, week 1, 2 weeks, 4 weeks, and following monthly for 6 months for the BCVA and any any complications with the associated with surgery, graft rejection, graft failures. Epithelium healing was checked with the help of fluorescence dye. Bondage contact lens was removed after 1 month. Patients were also given NSAIDs, vitamin C, and capsule doxycycline. This is an ASOCT picture which is showing on a period of 2 weeks, 6 weeks, and 6 months, in which there is a formation of a cyst, which is actually a collection of the inflammatory cells in the granulation tissue. And in 6 weeks' time, this cyst gets absorbed, and you can see under 6 months' time, it is completely absorbed and the cornea is intact layer. This is a case of a 37-year-old male with the right eye perforation, which was treated with the Bowman's membrane lenticule 4 weeks after surgery, well epithelialized. This is another case of corneal perforation, which was treated with the cyanoacrylate glue with VCL, but we performed a Bowman's membrane lenticule tuck-in surgery in such patients. And you can see the amazing results after 2 months of the surgery. The cornea is clear. This is another case, which is showing the timeline on post-operative 7 days, 4 weeks, and 6 weeks, with the complete epithelialization reached in average time of 4 weeks. These are my results. So on discussion panel, most of my patients were males, since the traumatic etiology mostly happens in the male patients. The mean gain in BCVA was more than equal to 0.6, which was significant with a p-value of less than 0.005. Mean age was 28.5 plus 3.69. Epithelialization time, which we found out, was 2.7 weeks. So the main outcome and the results of the surgery were discussed in terms of patients' subjective symptoms, which were dramatically reduced. Patients did not complain of any foreign body sensations on blinking, no watering, no pain. Patients did not have any ocular discomfort. They were happy with the surgery, did not want to go any further. In our study, the inflammation decreasing the inflammation was very fast with use of Bowman's membrane lenticule after the surgery because of the trophic effect of the Bowman's membrane itself. It was also helping in the transparency of cornea with the diminished fibroblast responses. The second was there was a formation of a cyst which was below the membrane.
Conclude it fast.
Sorry. The conclusions of my study is that the perforations of traumatic etiologies, are amenable to standard surgical repair. So Bowman's membrane tuck-in is a novel surgery. It is sutureless, it is glueless, and it can be used for the microperforations of non-effective etiology in the emergency settings. Surgery has a small learning curve. It uses therapeutic grade corneas which are rejected for optical use, and their patients have short hospital stays. They have quick recovery with the formed anterior chamber. There is no toxicity to the endothelium and lens. And it has a short-term post-op regimen with a significant improvement in the quality of vision. And so it also can provide better visual rehabilitation in acute cases, unlike cyanoacrylate glue, which only provides a mechanical barrier and an optimal environment for a patient to undergo another surgery, such as PKP or TPK. Bowman membrane is another plus point is it is an acellular layer, so there are complication of graft rejection of failures were dramatically reduced since it was non-antigenic. Limitations of our study includes the small sample size, follow-up period of only 6 months, which was short to assess the long-term effects. Larger prospective randomized trials are needed to be done, further investigated with longer follow-ups. It also had an unbalanced sex ratio with no patient under 18 years of age, and it was performed on corneas which were treated with cyanoacrylate glue with BCL. Thank you so much. So these are the articles published in Cornea, PubMed about the same. A case report was published in Cornea about 2 cases managed with the Bowman's membrane lenticule. And in PubMed, the articles were on the use on non-healing ulcers, neurotrophic ulcers. And this was the article present in the Saudi article on the new approach for the management of neurotrophic ulcers, Bowman membrane lenticule tuck-in. These are my references. Thank you for your time.
Okay, doctor. Thank you. The next presenter is Dr. Himaza. She's going to present a fibrin glue versus autologous blood in primary pterygium surgery.
Good morning, sir. Today I am going to present on comparative study of fibrin glue versus autologous blade for conjunctival autograft fixation in primary pterygium surgery. So there is no financial disclosure in this study and it is approved by IC and SRC. And coming to brief introduction about pterygium, which is a wing-shaped triangular encroachment of subconjunctival tissue into the cornea, and which occurs due to exposure, mostly due to exposure to UVB rays, and which is seen most commonly nasally. And there are mainly 3 clinical grades. Grade 1, where the pterygium tissue is reaching the limbus. Grade 2, between limbus and pupillary margin. And grade 3, which reaches pupillary margin or crosses to opposite side. And it is seen with a prevalence of 0.7 to 33% globally, and it is common in our part of world due to excessive UV light, hot and dry climate, especially in rural areas. And since there is no medical management for this treatment, it needs surgical removal. Various surgical options available are excision of pterygium followed by base sclera technique, which is not followed nowadays due to 88% recurrence. And one other is amniotic membrane grafting and conjunctival limbal autograft. And this conjunctival limbal autograft can be done either with sutures or fibrin glue or with autologous blade. And coming to brief procedure, in fibrin glue, the autograft was adhered to the underlying scleral bed by the glue. In autologous blade, the blood either oozing from the fractured vessels or the capillary is purposefully fractured in the scleral bed and allowed to form a clot. And over this formation of clot, this autograft was placed. Coming to aim of this study, to evaluate surgical outcomes following clad with fibrin glue and with autologous blade. And objectives of this study are to study efficacy of clad fixation with fibrin glue and with autologous blade, and to compare post-operative complications, and to study in terms of cost effectiveness. And this study is conducted in the Department of Cornea, Shankar Foundation Eye Hospital and Institute Visakhapatnam, with a study population of 190 patients divided into 2 groups. Group A 95 patients with fibrin glue and Group B 95 patients with autologous blade. And it is a prospective interventional study which is conducted from June 2022 to May 2023 with patients followed on post-operative day 1, 7, 30 and 90. So this study included the patients with primary pterygium of both sexes who are aged above 16 years of age, and patients with grade 2 and grade 3 nasal pterygium. And this study excluded the patients with bipolar or recurrent or pseudopterygium, and patients who are having glaucoma, patients with any ocular surface diseases, and patients with previous history of ocular surgery or trauma. So coming to the results and observation of this study, according to the age, it was most commonly found in the age group of 46 to 60 years of age with the 62% of 62% prevalence, and it was most commonly found in the left eye with the 52%, and it is most commonly seen in the males with 66%. And coming to the occupation, it was most commonly found in outdoor workers, which included manual laborers as well as farmers with 72% compared with only 28% which was found in indoor workers. And so this is the final slide, which is comparison between 2 groups, that is post-operative complications comparison between fibrin glue and autologous blade. These are the complications which are compared: graft loss, edema, post-op granuloma, infection, hemorrhage under the graft, recurrence and graft dislodgement. So in these 2 groups, hemorrhage was found in 27% in fibrin glue and 31% in autologous blade, and the recurrence was not noted in this study as the follow-up period was only for 3 months. So number of patients studied in this number of patient studies was 190, and age group of 45 to 60 years were more commonly affected, that is with 55%, and males were more commonly affected when compared to females with 67%, and outdoor workers were more commonly affected when compared with indoor workers with 72%. Next slide. So complications noted were slightly higher in autologous group, but no significant difference was present between the 2 groups, which is correlating with the studies. So coming to the final conclusion of the study, the economical factor and post-operative discomfort which is seen with fibrin glue was reduced with the use of autologous blade, and autologous blade was as effective as fibrin glue in the treatment of primary pterygium surgery. Thank you.
Okay, doctor, thank you. Next presenter is Dr. Bindu Tejaswini. The topic is treatment outcome of fungal keratitis attending tertiary eye care center in North Cuddalore.
Good morning, everyone. Study title is Treatment Outcomes of Fungal Corneal Ulcers Attending Tertiary Care Eye Institute of North Coastal Andhra Pradesh. This study has no financial disclosure and the project has got approval from SRC and IEC. The reported incidence of corneal ulceration in India is 1,130 per million population, and fungi are the common etiological agents which account for 30 to 40% of all cases of seborrheic keratitis. Among the fungi, Aspergillus and Fusarium are the common fungal pathogens responsible for this. Ocular mobility in fungal corneal ulcer tends to be greater than in bacterial keratitis because of delayed diagnosis and available drugs of fungicidal. The objectives are to study treatment outcomes of fungal keratitis, to study demographic, microbiological and morphological features of fungal keratitis, and to study the role of TPK in preventing complication. The sample size is taken as 42. Inclusion criteria are all cases of fungal corneal ulcer attending cornea clinic and diagnosed positive for 10% KOH mount. Exclusion criteria are bacterial and viral keratitis, cases with any other corneal pathology causing visual impairment, fungal keratitis cases already started on treatment outside. This is a hospital-based prospective study conducted during a study period of 1 year from April 2022 to March 2023 and followed up for 3 months. The results showed the majority of the cases are among the age group of 41 to 50 years and more common in males, and majority of the patients belong to the agricultural background. More common in patients with trauma with vegetative matter followed by foreign body. On culture, most found organisms are Fusarium followed by Aspergillus. 57% cases are managed medically and 43% are needed surgical management. Of all the cases managed with medical treatment, 50% ended with macular scarring, 29% with nebular, and 21% with leukomatous scarring. Of all the surgically managed cases, 94% needed TPK and 6% needed patch graft. The outcome of TPK showed 70% failed grafts and 30% had clear grafts. The final outcome of all the patients, of all the medically managed cases, 11% had leukomatous scarring, 28% macular scarring, 16% with nebular scar. In the TPK cases, 11% had clear grafts and 28% failed graft, and 2% cases needed patch grafting. The summary of my study, of all the 42 cases studied, majority were men and from agricultural background. Almost 50% were among the age group of 41 to 50 years. Over 92% patients gave a definite history of trauma, with vegetative matter being the most common offending agent. The causative agent in majority showed Fusarium, Aspergillus, followed by Calvaria, and found negative in 7.5 cases. All patients are initially started on medical treatment with antifungal, cycloplegic, and followed for 3 months. Cases with the risk of impending perforation with medical treatment are managed surgically. The conclusion is, of all the 42 cases, 57% are medically managed and ended in low vision due to scarring, with the 50% cases with macular, 16% nebular, and 11% with leukomatous scarring. 43% cases are surgically managed. Of these, TPK is done for 17 cases and patch graft in 1 case. Of all the TPK cases, 70% were graft failures and 30% had clear grafts. Thank you.
The next presenter is Dr. Vivek, and he is going to present atypical oculomycosis, a case series in a tertiary eye care hospital.
Good morning everyone. Myself Dr. Vivek Nimje from Assam Medical College, Dibrugarh. I am going to present the case series on atypical oculomycosis in a tertiary care hospital. Introduction. Keratomycosis is an infection of cornea caused by multitude of fungal genera which are predominated by mainly Fusarium and Aspergillus, and much more exceptionally Lesiodiplodia theobromii. Keratomycosis caused by Lesiodiplodia are rare infection with very serious prognosis. The prototype species of Lesiodiplodia is Lesiodiplodia theobromii, an important cause of keratitis accounting for over 50 cases of corneal ulcer worldwide, and which are reportedly refractory to antifungal treatments. Lesiodiplodia, theobromine, and pseudotheobromine are established plant pathogen causing post-harvest fungal disease of grapevine yards, mango, and citrus plantation. Introduction: we report 3 cases of phytopathogenic Lesiodiplodia theobromine causing keratitis in northeast region in India. Aims and objective: to report the clinical presentation and role of voriconazole in the treatment of rare cases of fungal keratitis caused by Lesiodiplodia. Methods and material: it is a hospital-based prospective study in which corneal scraping of the from the base and edge of the ulcer was taken and sent for microbiological examination. 3 eyes of 3 patients with Lesiodiplodia were included in this study. Clinical scenario: case 1, a 50-year-old man came to the OPD with complaint of pain, redness, watering, and diminution vision with history of bamboo stick injury 20 days ago. On examination, there was a circumcorneal congestion and corneal ulcer of 3 by 3 mm size with feathery margin accompanied by hypopyon of 1 mm and desmetocele. The ulcer was situated at 7 to 9 o'clock position and extended up to nasal limbus. The ulcer was covered with slough and was extended up to desmet membrane of cornea. Pupil was mid-dilated, briskly reactive to light. His visual acuity in the left eye was hand movement close to face, corneal scraping done, and sent for microbiological examination. Patient started on eye drops natamycin and gutifloxacin on presentation. The culture in seborrheic dextrose agar with chloramphenicol yielded growth of grey colored floccous colony with black rivers after 7 days. It was identified as Lesiodiplodia theobromine after ITS sequencing. Antifungals was switched to 1% voriconazole eye drops 1 hourly. The patient came for follow-up after 2 weeks. There was symptomatic relief and regression of ulcer again returned for follow-up after 4 weeks. The eye showed good improvement with no signs of inflammation, and eye healed completely with a macular scar measuring the 2 by 3 mm covering the site of lesion, and visual acuity had improved to finger counting at 2 meters. Another case come with similar complaint and similar type of ulcer. Voriconazole was started in the same patient, and patient responded well to voriconazole. Case 3, similar patient but with lesser age, with history of entry of sand particles in the right eye was given, and on examination there was corneal ulcer 3 by 3 mm with feathery margin and hypopyon. Ulcer was central and covered with slough and extended up to stromal layer. Pupil and lens could not be visualized. His visual acuity in the right eye was hand movement close to face. Corneal scraping was done and sent for examination. The patient started initially on natamycin and gutifloxacin. The culture was found to be Lesiodiplodia, and the antifungal was switched to 1% voriconazole. The eye showed good improvement with no signs of inflammation, and eye healed completely with macular scar measuring 3 by 3 mm. Discussion: Lesiodiplodia theobromine is a dematicious filamentous fungus endemic in certain regions such as northeast region of India. It is a rare cause of keratomycosis, accounting for only 3% of fungal keratitis cases. Keratitis can be serious and rapidly progressive with high chance of corneal perforation leading to endophthalmitis and panophthalmitis. Management is often difficult as keratitis shows variable response to antifungal. A corneal injury, even a minor one, usually plant origin, is found in large number of patients who often develop infection with filamentous fungi, as was the case with our patient. Other risk factors include diabetes, immunosuppression, pre-existing ocular condition, and contact lens wearers. Clinically, corneal lesion can progress to an abscess or ulcer, even can lead to endophthalmitis. For recovery of vision, keratoplasty is often required. Voriconazole is a new generation triazole with fungicidal inactivity against Lesiodiplodia theobromine. It has good ocular penetration and low minimum inhibitory concentration. Therapeutic aqueous drug can be achieved at low doses. Rebel et al. Conclude in a study that
already session running late. Conclude it fast.
Okay. Conclusion: Lesiodiplodia theobromine keratitis is a rare infection but can cause serious keratitis leading to blindness. Early use of topical voriconazole 1% may provide effective treatment option for oculomycosis caused by Lesiodiplodia species. Keratoplasty is often required for corneal opacity after healing. Thank you.
Okay. Next presenter, Dr. Jaya Kaushik. Dr. Jaya Kaushik is here. Dr. Praful Maharana. One more session. Liz. Finalist has to present again, sir. Cornea 1 finalist, final presenter, sir. Yes. Dr. Pankaj Dongre. Congratulations, Dr. Pankaj. He is the yesterday's Cornea 1 finalist. He has to present again in the Cornea 2 finals. This is the final presenters. No, sir. The process is different in these sessions.
Yeah, good morning everyone. So the topic for my paper is central toxic keratopathy post-collagen cross-linking. Slides are not moving. So I have no financial disclosure to disclose. So the purpose of this study was to report a case series of central toxic keratopathy post-collagen cross-linking in keratoconus. It was a retrospective case series which included 12 eyes out of 964 eyes who underwent collagen cross-linking for progressive keratoconus, and the protocol followed was epithelium of accelerated protocol using the Avedro KXL cross-linking system. After the CXL, BCL was applied for 1 week along with the routine topical medications. So out of the 12 patients who had developed CTK, there were equal number of male and females, and the age group was between 16 to 32 years. This is a table which shows that almost all the patients presented to us within 1 week of post-CXL, and all has the characteristic features of the CXL, which I will be discussing in the subsequent slides. So we can see when the patient presented to us at 1 week with this clinical picture, where we can see there is a central stromal opacity along with striae radiating from the opacity. There is no any congestion of the conjunctiva. Important to know, there is no any epithelial defect and no AC reaction. So the location of the opacity was central, not peripheral, with very distinct borders along with underlying stromal thinning. The ASOCT shows the hyperreflectivity where the opacity is present, and the hyperreflectivity was more in the anterior stroma compared to the posterior stroma, with a characteristic inverse dome-shaped pattern. So this was the topography of the patient, which shows that there was a significant corneal flattening compared to the preoperative level. The confocal microscopy shows the activation of keratocytes, but there are no any inflammatory cells. As we can see, over the time the opacity fades away, and ASOCT shows there is significant stromal thinning just below the opacity. This is the graphical representation which shows that there is significant, in the acute phase of CTK, there is significant corneal flattening, and in the remodeling phase, the cornea regains, becomes steeper, but the steepness is still less compared to the preoperative level. Also, the pachy of the thickness of the stroma decreases in the acute phase of CTK. So the CTK, it is a non-inflammatory self-limiting condition which is commonly seen after the laser refractive surgery, most commonly after LASIK, where we can see there is stromal tissue loss, striae, and due to the stromal tissue loss, there is significant hyperopic refractive shift. Important thing to know is that it has not been reported post-collagen cross-linking. So as there is loss of stroma, the anterior surface falls back to fill the gap, causing flattening of the anterior surface of the cornea and hyperopic shift. So these are the probable external factors which play a role in the formation of CTK. The topography shows over the period the significant flattening, and in the remodeling phase the cornea becomes steeper, but the steepness, as I told, is still less compared to the preoperative level. So due to the stromal remodeling, there is increase in the corneal thickness, which causes change in the refractive index of the stroma, resulting in reduction in the hyperopic shift after the remodeling phase. So the diagnostic features on tomography include the exaggerated anterior corneal flattening with corneal thinning, ASOCT shows inverse dome-shaped opacity with backscattering, and the confocal microscopy shows no inflammatory cells. So it is a self-limiting disease which resolves spontaneously in 2 to 18 months, and the topical steroids have no role in the treatment of this condition. On the contrary, it may worsen the disease. So CTK can occur post-collagen cross-linking. It is a non-inflammatory condition, self-limiting, and topical steroids are better to avoid in this condition. Thank you.
Thank you, Pankaj. Okay, next session will start in few minutes.